Good day, everyone. We are Group 1 from BSN 4C, and we will be tackling gastric cancer as one of the problems that we will encounter in the digestive system. Gastric cancer is a disease in which malignant cancer cells form in the lining of the stomach. Age, diet, and stomach disease can affect the risk of developing gastric cancer. Moving on to the signs and symptoms of gastric cancer, we have in the early stages of gastric cancer, the following symptoms may occur. First is indigestion and stomach discomfort. Second is a bloated feeling after eating. Third is mild nausea. Fourth is the loss of appetite. And fifth is heartburn. In more advanced stages of gastric cancer, the following signs and symptoms may occur: blood in the stool, vomiting, weight loss for no known reason, stomach pain, jaundice, or what we also call the yellowing of eyes and the skin, ascites, or the buildup of fluid in the abdomen, and trouble swallowing. Causes of gastric cancer. The main cause of stomach cancer is a genetic mutation or the change in the cells of the stomach, which then causes the cells to grow rapidly and eventually form a tumor. Risk factors that can increase a person's chance of getting stomach cancer include family history, smoking, obesity, infection from Helicobacter pylori bacteria, and a diet high in salt, and a diet that does not include many fruits and vegetables. We have any of the following medical conditions, such as the Helicobacter pylori, infection of the stomach, chronic gastritis, or what we call the inflammation of the stomach, pernicious anemia, intestinal metaplasia, which is a condition in which the normal stomach lining is replaced with the cells that line the intestines, gastric polyps, and the familial syndromes including familial adenomatous polyposis. Another risk factor is the eating of a diet high in salted, smoked foods and low in fruits and vegetables, eating foods that have not been prepared or stored properly, being older or male, smoking cigarettes, and having a mother, father, sister, or brother who has had stomach cancer. We will now be moving on to the statistical distribution both locally and globally. Stomach cancer mostly affects older people. The average age of people when they are diagnosed is 68 years of age. About 6 of every 10 people diagnosed with stomach cancer each year are 65 or older. So according to the latest World Health Organization data published in 2018, stomach cancer deaths in the Philippines reached 1,954 or 0.32% of total deaths. The age-adjusted death rate is 2.89 per 100,000 of population which ranks the Philippines number 157 in the world. The lifetime risk of developing stomach cancer is higher in men, about 1 in 96, than in women, about 1 in 52. But each person's risk can be affected by many other factors. Introduction to anatomy and physiology. We have the stomach. The stomach is a muscular organ located on the left side of the upper abdomen. The stomach receives food from the esophagus. As the food reaches the end of the esophagus, it enters the stomach through a muscular valve called the lower esophageal sphincter. The stomach secretes acid and enzymes that digest food. We will now be tackling the different parts of the stomach. First, we have the cardia. It is the top part of our stomach. It contains the cardiac sphincter, which prevents food from traveling back up your esophagus. Second is the fundus. It is the rounded section next to the cardia, and it's below our diaphragm. Third is the body, or also known as corpus. It is the largest section of our stomach, and in the body, our stomach contracts and begins to mix food. Fourth is we have the antrum. This lies below the body and it holds food until your stomach is ready to send it to the small intestine. Lastly is the pylorus. It is the bottom part of our stomach, and it includes the pyloric sphincter. This ring of tissue controls when and how your stomach contents move to your small intestine. The abdomen region can also be divided into 4 quadrants. These quadrants are defined by the intersection of the sagittal plane with the umbilical plane. Physicians use these regions to determine the organs and tissues that may be causing pain or discomfort in that region. We have the right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. It is also divided into 9 divisions. First, we have the right hypochondriac. The right hypochondriac region contains the right portion of the liver, the gallbladder, the pancreas, and parts of the colon. The left hypochondriac region contains part of the spleen, the left kidney, part of the stomach, the pancreas, and parts of the colon. The epigastric region, which is above the stomach, contains the majority of the stomach, parts of the liver, parts of the pancreas, parts of the duodenum, part of the spleen, and the adrenal glands, and this region pushes out when the diaphragm contracts during breathing. Right lumbar. This consists of the gallbladder, the right kidney, part of the liver, and the ascending colon. Left lumbar. The left lumbar region consists of the descending colon, the left kidney, and part of the spleen. The umbilical region contains the umbilicus or the navel and many parts of the small intestine, such as part of the duodenum, the jejunum, and the ileum. It also contains the transverse colon, the section between the ascending and descending colons, and the bottom portions of both the left and right kidney. Right iliac. The right iliac region contains the appendix. The right iliac region contains the appendix, cecum, and the right iliac fossa. It is also commonly referred to as the right inguinal region, and pain in this area is generally associated with appendicitis. Left iliac. The left iliac region contains parts of the descending colon, the sigmoid colon, and the left iliac fossa. It is also commonly called the left inguinal region. Hypogastric. The hypogastric region, which is below the stomach, contains the organs around the pubic bone. This includes the bladder, part of the sigmoid colon, the anus, and many organs of the reproductive system, such as the uterus and ovaries in females and the prostate in males.
Hey everyone, my name is Charles Kenneth Albuslan, and for today's video, I will be discussing objective number 2, which talks about the disease pathophysiology of gastric cancer, in which I will be emphasizing the predisposing and precipitating factors of gastric cancer, its disease process, signs and symptoms, the clinical and the classical, and the different management for gastric cancer. So without further ado, let's begin. As what you can see here on your screen is the schematic diagram of the pathophysiology of gastric cancer. So first, we have the predisposing factors. So I have listed here 2. First, we have the family history of gastric cancer. Since gastric cancer has a genetic predisposition in which when a person has a family member who has gastric cancer, it increases his or her risk in acquiring gastric cancer as well. Second, we have age. So gastric cancer is more common among 40 years old and above older adults. So in this age group, the progression of gastric cancer is faster compared to the other age groups. Now let's move on to the precipitating factors of gastric cancer. So first, we have diet. So a diet that is high in salt and smoked foods and low in fruits and vegetables. So salty and smoked foods increases the risk of gastric inflammation, while fruits and vegetables are a good alkalizing agent which balances the acidic environment in the stomach. So a diet that is low in fruits and vegetables has a higher risk of having an acidic environment in the stomach, which increases the risk of disruption in the stomach lining or ulceration. Second, we have infections such as Helicobacter pylori. So it is known that when there is infection, then the inflammation process follows. So when inflammation is present, then it increases the risk of developing gastric cancer. Third, we have obesity. So according to study, more than 5% of gastric cancer is caused by obesity. And fourth, we have smoking. So smoking is not only a precipitating factor of gastric cancer, but also to several other cancers as well. And according to studies, specifically in UK, 1 out of 5 gastric cancers is caused by smoking. And lastly, we have gastric disorders, which includes GERD, gastritis, and gastric polyp. So when these disorders occur, then it increases the risk of having inflammation in the stomach, which increases the risk of having gastric cancer. And when these two factors are not being controlled, then it will develop into gastric cancer. Hence, the disease process would follow. So first, the infection. So when there is an infection, then there is the presence of inflammation. But it's also important to note that gastric cancer has different pathophysiology depending on the cause of gastric cancer. And as what you can see here on the screen in the pathophysiology, this is an example of an intestinal type opposing to the diffuse type. So the intestinal type is more common among older adults, 40 years old and above, specifically men. So it starts with inflammation, such as when there is an infection, and it develops into superficial gastritis in which the stomach lining is being affected. And then it progresses, which develops into atrophic gastritis in which the gastric glandular cells are being replaced by fibrous tissues. And when this occurs, then it progresses into intestinal metaplasia in which the lining of the stomach resembles the intestinal lining. And at this point, it will now be a precursor of gastric cancer already. And when intestinal metaplasia would still develop further or would still undergo a series of transformation, then dysplasia would occur in which the precancerous cells are already developing, which would lead to gastric cancer. And when gastric cancer is already present in the stomach, then the person would now feel the signs and symptoms of gastric cancer. So as what you can see here on the screen is the second portion of the schematic diagram, in which when gastric cancer is already present in a person, then the person may manifest the following signs and symptoms. So first, we have the clinical signs and symptoms, which includes a person may have difficulty swallowing, feeling bloated after eating, experience heartburn, and indigestion. And we have the different classical signs and symptoms, which include feeling nauseous, vomiting, stomach pain, and unintentional weight loss. And when these signs and symptoms are present, then the person will undergo the following management. So we have first medical management, which includes radiation therapy. So in radiation therapy, it makes use of radiation to kill cancer cells. And next, we have chemotherapy, or the utilization of drugs and chemotherapeutic agents to control or to kill cancer cells to prevent it from proliferating and growing. Third, we have targeted therapy, which targets specifically the genes, tissues, and the proteins that surround the cancer cells to be able to control and kill these cancer cells to prevent it from metastasizing or from developing. And fourth, we have immunotherapy. So this is a biologic therapy which boosts the defense system to be able to fight the cancer. And lastly, we have supportive or palliative care, which is intended when gastric cancer is already too serious or on its terminal stage, and it is more directed on pain management and providing comfort to the client. Next, let's talk about the different surgical managements for gastric cancer. So first, we have total gastrectomy, or the removal of the entire stomach. Second, subtotal gastrectomy, or the removal of a portion of the stomach. And third, we have the esophagogastrectomy, or the removal of the esophagus and a portion of the stomach. Fourth, we have lymph node dissection, or a removal of a portion of the lymph nodes. And lastly, we have the gastrojejunostomy, or the removal of a portion of the stomach and connecting it to the jejunum. So for the surgical management, it is basically based on the severity of gastric cancer and the area of the stomach that is being affected. And now let's talk on the different nursing management for gastric cancer. So when you talk about nursing management for gastric cancer, it is very broad and it is specific to the specific treatment that a person will undergo. So I have listed here a general nursing management that can be applied when a person has gastric cancer. So these includes providing comfort measures and administering analgesics as ordered, since in the signs and symptoms, a person may feel stomach pain or like pain in general. Second is the frequent turning of the patient and encouraging deep breathing to prevent pulmonary complications. And third is to maintain NGT suction to remove fluids and gas. Fourth is to provide oral care to prevent dryness and ulceration. And fifth is to eat small, frequent meals rather than large meals. So there are still a lot of other nursing management that you can do for a client that has gastric cancer, but these are just some of the examples that a nurse can do for a client that has gastric cancer. So this ends my report on the pathophysiology of gastric cancer, and I hope that you've learned something. Thank you and have a good day.
Good day everyone, my name is Tony Marie P. Caplitan and I'll be reporting Task 3, which is to present the 3 priority nursing diagnoses, which includes a psychological, physiological, and wellness, along with its 10 nursing interventions for each nursing diagnosis, which includes a 4 independent, 4 dependent, and 2 interdependent nursing interventions. So let us begin. For the physiological nursing diagnosis, I have created here imbalanced nutrition, less than body requirements related to anorexia, difficulty eating, and nausea. I also have here for the psychologic, anxiety, rumination related to disease and anticipated treatment, and lastly for wellness, readiness for enhanced knowledge about condition. So let us start with the first one. So we have physiologic deficit, imbalanced nutrition, less than body requirements related to anorexia, difficulty eating, and nausea. For the interventions, we have measures to demonstrate behaviors, lifestyle changes to regain and or maintain appropriate weight. For the independent nursing actions, we have encourage a client to eat small, frequent portions of non-irritating food, so this is to decrease the gastric irritation. Second, provide food supplements high in calories, vitamins A and C, and iron, since this provides the necessary nutrients for the client and for optimal nutrition. Third, discourage caffeinated or carbonated beverages, since these beverages will decrease the hunger of the client and lead to early satiety. And lastly, for the independent nursing actions, we have encouraged use of relaxation techniques, visualization, guided imagery, moderate exercise before meals, and also control environmental factors, as well as avoid overly sweet, fatty, or spicy food, since this may prevent the onset or reduce the severity of nausea, and can also decrease anorexia and enable the patient to increase the oral intake. For the dependent, we have considered the possible need for enteral or parenteral nutritional support with the client, family, caregiver as appropriate, since nutritional support may be recommended for those who are unable to maintain nutritional intake by the oral route. We have administered vitamin and mineral iron supplements or digestive drugs or enzymes as prescribed. Also administer antiemetic on a regular schedule before, during, and after administration of anti-neoplastic agent as appropriate. And we have to review the drug regimen, side effects, potential interactions with other medications and over-the-counter drugs. So this is to minimize the side effects of the drugs such as nausea. And we have to administer these vitamins and mineral supplements since the client needs the optimal nutrition. And for the interdependent, we have collaborate with a dietitian or nutritionist for proper diet, and collaborate in the treatment of gastric cancer or other underlying causative factors. For the second nursing diagnosis, we have psychologic overload, anxiety, rumination related to disease, and anticipated treatment. For the interventions, we have measures to reduce anxiety. For the independent nursing actions or nursing interventions, we have number 1, establish a therapeutic relationship conveying empathy and unconditional positive regard. Therapeutic skills need to be directed toward putting the client at ease because the nurse who is a stranger may pose a threat to the highly anxious client. So that is very important to establish a therapeutic relationship with your client. Second is to encourage the client to acknowledge and to express feelings. Clarify meanings of feelings and actions by providing feedback and checking meaning with the client. So talking about anxiety-producing situations and actions, feelings, can help the client perceive the situation realistically and recognize factors leading to anxious feelings. Third is consider the client's use of coping strategies that the client has found effective in the past. Assist the client in developing new anxiety-reducing skills such as relaxation, deep breathing, positive visualization, and reassuring self-statements, since the client's past coping methods can be helpful in reducing the client's anxiety, and also finding out or discovering new coping methods can also provide the client ways to manage anxiety. Fourth, explain all activities, procedures, and issues that involve the client, and use non-medical terms and calm, slow speech, and do this in advance of procedures when possible and validate the client's understanding, since this can help the client in reducing anxiety and emotional distress. For the dependent nursing interventions, we have administer anti-anxiety medications as ordered by the physician, and also educate the client about the drug's benefits, side effects, and proper administration details. Should also administer as needed or PRN medications during panic attacks, and review medication regimen and possible interactions, and also refer to the physician for drug management, alteration of the prescription regimen. Short-term use of anti-anxiety medications can enhance patient coping, and panic attacks that the client may experience can be resolved by giving some antidepressants such as SSRIs. For the interdependent nursing actions or nursing interventions, we have refer the client to individual and or group therapy as appropriate, since these individual or group therapy can provide support to the client and can help the client deal with his or her anxiety. And lastly, we have refer individual to a therapist, since the client can learn to identify and manage the factors that contribute to their anxiety. And the patient or the client can also have psychological counseling or talk therapy to cope with the symptoms. So for the third nursing diagnosis, we have our wellness nursing diagnosis, which is the readiness for enhanced knowledge about the condition. So we have measures to enhance knowledge. For the independent nursing interventions, we have to examine and verify the client's current knowledge about gastric cancer, since this provides accuracy and completeness of knowledge base for future learning. Second, assist the client to identify learning goals and client preferred methods of learning, since this helps to provide a measure to evaluate the learning process and also identifies the best approaches to facilitate the learning process. Third, motivate the client to ask questions or clarifications for their health concerns, since asking questions can help the client in his or her plan of care, and this also informs the nurse about what matters to cover next. Fourth, assist the client in incorporating new information about gastric cancer and its management into his or her daily life, since this assists the client in constantly making adjustments that will produce positive outcomes in behavior. For the dependent nursing interventions, we have to encourage the client to take medications as prescribed by the physician and review drug regimen. Also, follow proper scheduling and therapy regimen for gastric cancer and provide explanations about what to expect, including the length of treatments and expected side effects. We also have to instruct the client about the prescribed diet, nutrition, and treatment regimens, activity and lifestyle changes, pain management, and possible complications, as well as discuss follow-up consultations as ordered by the physician. So these are very important since taking the prescribed medications is necessary for effective treatment. And for the effectiveness of the therapy, the client must be aware of what is needed and what to do. And regular evaluation for client participation is crucial for the therapy success. And lastly, for the interdependent nursing interventions, we have to identify available community resources and support groups and collaborate with nutritionists and dietitians since the community resources provide support for the client for his or her condition, and nutritional counseling is important for the client's condition, and he or she may need administration of enteral and parenteral feedings. So that'll be all, and thank you so much.
Good day, everyone. I am Trisha Claire Apelianes, and today I'll be going to report task number 4, which is to enumerate at least 5 medical and surgical management, and in a table format, provide the drug of choice, including its classification, the dose, the mechanism of action, and at least 3 nursing responsibilities. Without further ado, let's begin. We have here the medical and pharmacologic management. First, we have radiation therapy. So this uses high-powered beams of energy such as X-rays and protons to kill cancer cells. People with gastric cancer usually receive external beam radiation therapy, which is radiation given from a machine outside the body. This may be used before surgery to shrink the size of the tumor or after surgery to destroy any remaining cancer cells. We also have chemotherapy. So this can also be given before surgery to help shrink the cancer so that it can be more easily removed, and also used after surgery to kill any cancer cells that might remain in the body. This is often combined with radiation therapy that may kill more tumor cells. Common chemotherapy drugs for gastric cancer are fluorouracil, doxycycline, oxaliplatin, capecitabine, cisplatin, and epirubicin. Then we have targeted therapy. So this is the type of treatment that uses drugs or other substances to identify and attack specific cancer cells. It usually causes less harm to normal cells than chemotherapy or radiation therapy would do. Monoclonal antibodies and multikinase inhibitors are types of targeted therapy used in the treatment of gastric cancer. Examples of monoclonal antibody drugs includes trastuzumab, ramucirumab, and for multikinase inhibitors, we have regorafenib. Third, we have immunotherapy. So this is a drug treatment that helps your immune system to fight cancer. The substances made by the body or made in a laboratory are used to boost, direct, or restore the body's natural defenses against the said cancer. Common drugs used includes ipilimumab yervoy, pembrolizumab Keytruda, nivolumab Opdivo, and atezolizumab Tecentriq. And then lastly, we have supportive or palliative care to be given to the patient, especially when the condition is serious. So this is a medical care that focuses on providing relief from pain and other symptoms of a serious illness. Palliative care can be used while undergoing aggressive treatments such as surgery, chemotherapy, or radiation therapy. And it is offered alongside curative or other treatments you may be receiving. Moving on to the surgical management, we have subtotal gastrectomy, which is the removal of the part of the stomach that contains the said cancer. And also nearby lymph nodes and parts of other tissues and organs near the tumor. Another option would be the total gastrectomy. So which is the removal of the entire stomach, nearby lymph nodes and parts of the esophagus, the small intestine, and other tissues near the tumor. The spleen may be removed as well, and that the esophagus is then connected to the small intestine so the patient can continue to eat and swallow. According to the study by Giovanni Di Manzoni et al., patients undergoing subtotal gastrectomy presented a better outcome than total gastrectomy. If and when the tumor is blocking the stomach but the cancer cannot be completely removed by standard surgery, the following procedures may be used. First is the endoluminal stent placement, which is a procedure to insert a stent, which is a thin, expandable tube, in order to keep a passage such as the arteries or the esophagus open. For the tumors blocking the passage into or out of the stomach, surgery may be done to place a stent from the esophagus to the stomach or from the stomach to the small intestine to allow the patient to eat normally. Then the second one, we have gastrojejunostomy, which is a surgery to remove the part of the stomach with cancer that is blocking the opening into the small intestine. The stomach is connected to the jejunum, which is a part of the small intestine, to allow food and medicine to pass from the stomach into the small intestine. So that's for the medical and surgical management. For the drug of choice, we have eloxetine oxaliplatin. So its classification, it is a anti-neoplastic alkylating agent. For the dose, for adults only, the recommended dose for oxaliplatin in an adjuvant setting is 85 mg per m2 intravenously repeated every 2 weeks for 12 cycles or for 6 months. And then also the recommended dose for oxaliplatin for the treatment of metastatic cancer is 85 mg per m2 intravenously repeated every 2 weeks until disease progression or unacceptable toxicity. Then for the mechanism of action, oxaliplatin undergoes non-enzymatic conversion to active derivatives via displacement of the labile oxalate ligand. After its activation, oxaliplatin binds preferentially to the guanine and cytosine molecules of DNA, leading to cross-linking of the DNA, thus inhibiting DNA synthesis and transcription. Then for the nursing responsibilities, we need to assess the patient, confirm its allergies, and evaluate any pre-existing symptoms. Verify signed consent for treatment was obtained and signed by the provider and the patient itself. Take measures to prevent medication errors by double-checking the accuracy of the treatment regimen, the chemotherapy agent, the dose, the calculations of the body surface area, the schedule, and the route of administration. Continuous patient monitoring for acute or adverse drug effects and allergic reactions. We also need to document medications given, the patient response, including any adverse events. And then lastly, we need to ensure patient has appropriate discharge instructions, anti-nausea medications, and emergency contact information of the physician's office in the event of any emergency situation. So that's it for task number 4. Thank you so much for listening and have a great day ahead.
Hi, I am Dimples Espilia and I will be discussing Task 5. I'll be presenting a table with the procedure gastric lavage or NGT feeding with the rationale and scientific and bioethical principles, and I will be also discussing the possible legal problems that may arise during NGT feeding and ways to prevent it. Gastric lavage or NGT feeding is a process of feeding a patient through a nasogastric tube. The first step is to check the doctor's order, which is done to ensure that the procedure was ordered by the physician and to ensure that it is done on the right patient. This follows the principle of safety and security. The bioethical principle for this is non-maleficence. The second step is to explain the procedure to the client to alleviate anxiety following the principle of psychology and sociology. The next step involves performing hand washing to prevent the spread of microorganisms following the principle of microbiology and preparing the necessary materials to save time and energy. These steps follow the bioethical principle of responsibility, accountability, and beneficence. The next step is to warm the feeding to prevent gastric cramping. Then the patient is then positioned in a Fowler's position to prevent aspiration, then an aseptic syringe is attached to the NGT. These all follow the scientific principle of safety and security. Warming the feeding and proper positioning follows the bioethical principle of responsibility, accountability, and non-maleficence, while attaching the aseptic syringe to the NGT follows beneficence. The next step is to check for the placement of the tube in the stomach, which is done to ensure that the tube is properly placed in the stomach following the principle of safety and security and anatomy and physiology. These follows the bioethical principle of responsibility, accountability, beneficence, and non-maleficence. The next step is to kink the NGT to prevent air from entering the stomach, promoting safety and security, and to prevent harm. Next step is to hold the syringe above the stomach to promote movement following the principle of physics. This follows the bioethical principle of responsibility, accountability, and beneficence. Pour the feeding into the aseptic syringe, then releasing the kink, controlling the administration and flow rate to prevent air from entering the stomach following the bioethical principle of non-maleficence. The next step is to continue feeding to ensure that the prescribed volume is given. Both steps are done to ensure safety and security, and it follows the principle of beneficence. After feeding, drinking water is poured to clear the tube. This follows the principle of physics and the bioethical principle of non-maleficence. The drape is then removed following the principle of microbiology and the bioethical principle non-maleficence. The client must remain in an upright position to prevent aspiration, which follows the principle of anatomy and physiology and safety and security, and also follows the bioethical principle of non-maleficence and beneficence. After care is done to prevent the spread of microorganisms and follows the principle of beneficence. The last step is to document to provide continuity of care, which is done for safety and security, and follows the bioethical principle of responsibility and accountability. For the next part, I will be identifying possible legal problems that may arise in the performance of NGT feeding and how it could be prevented. Number 1. Malpractice. The misplaced tube may cause the formula to enter the lungs because of the proximity of the larynx to the esophagus. The nasogastric tube may enter the larynx and the trachea, which may cause aspiration. In some instances, when tubes are incorrectly placed in the bronchial tree, it causes severe sepsis, which can be fatal and may harm the client. So this can be prevented by securing a doctor's order before performing NGT feeding, following the principle of microbiology, performing proper feeding procedures, which is to position the patient in a Fowler's position to prevent aspiration, assessing the tube placement prior to feeding by auscultating for bowel sounds by instilling air, using the aseptic syringe, and aspiration of gastric contents. Third, kinking the NGT to prevent air from entering the stomach. And fourth, we have letting the client sit in an upright position 30 minutes after feeding. Another legal problem that may occur is negligence, which is an act of omission or commission that does not meet the established standards of care. It can be prevented by doing proper feeding procedures, proper documentation, monitoring patient for aspiration, and explaining the procedure. And lastly, we have documentation errors which may also occur, so it is important that the nurse charts the type and amount of feeding, time of feeding, and client's response during and after the procedure immediately. So that's it for my part. Thank you.